Whether or not it's genetic that we start to produce much less insulin than we should be producing at this age, or it's a factor of the relative insufficiency in insulin because our eyes are so big, we eat enough food, but we're not expending it, and we have a relative excess of sugar molecules, hence the reason for us to start storing the glucose molecules into the liver. Now it becomes converted to fat, and then we develop this big truncal set of fat. We induce obesity in our cells by our food intake. Now, in the case of type 1 diabetes, it's either due to the fact that we have a genetic condition we're producing less insulin, or we have a condition in which our eyes feels that it should be satisfied with food rather than our stomach. So we eat excessive amounts of food. In that case, we do not have enough insulin. Now we say to our body, we're going to produce more insulin by squeezing the pancreas to produce that insulin, or decreasing the insulin absorption from the periphery. In that case, now the type 1 diabetic can be controlled by 1. Decreasing your food intake, increasing the expenditure of energy by exercising, increasing your muscle mass, which is much more efficient at burning calories than fat is. 3 simple rules we can actually control our type 1 diabetes. By controlling our type 1 diabetes, we may not be discontinuing our medication, but we'll be using much less medication. Because by using much less medication, you're actually saving money, and we're also decreasing the side effects of large doses of medication. The whole rationale behind this is understand fully well. The less food, the less sugar molecules. The less sugar molecules here, either by increasing the insulin from the pancreas by medication, will decrease this. And I want you to remember this picture. This picture says how much sugar molecules, this is your red blood cells, and this is the sugar molecules. The sugar was not able to get into this person's cell because they did not have enough insulin. They were diabetic, or either from excessive amount of food intake. They became relative insufficiency of insulin. I want you to remember this picture. With the excessive amount of glucose, the cell itself is now dry. It's not functioning. We feel tired, we feel fatigued, we feel dried. Now I want you to understand that in the next discussion, I will tell you what are the implications of having a large and excessive amount of sugar, that this will now going to be forming what is going to be the bone of the damage to the eye, the heart, the kidneys, the nerve damage, the damage to the gums, the diseases of the mouth, and also the feet. Those are the complications of diabetes that we'll try and conclude in our next presentation. In continuing our dialogue on diabetes, because it is such a dangerous disease that can be so easily controlled and contained by just altering our way of life, it's so important for us to learn as much as we possibly can from diabetes. In the presentations we've done so far, we've actually alluded to how is it that sugar is absorbed, how is it that insulin is secreted, what is the role of insulin, what is sometimes the role of medications that we take. A common question always asked is, do I have type 1 diabetes or type 2 diabetes? Very simple. In type 1 diabetes, you're not producing any insulin. Can it occur at any age? It can occur in most of the youngs, the teenagers who develop diabetes, develop type 1 diabetes, meaning in terms of that they do not produce any insulin. A very rare condition, but a real condition in which you produce antibodies against your own beta cells of the pancreas, and you do not produce insulin. From a very early age, that person is expected to take insulin for the rest of their lives. Type 2 diabetes can occur at any age. Usually, the way it occurs is that basically we start to produce less insulin as we get older, and all of us are the same. But it's also a genetic propensity for some families to produce much less insulin, combining with the fact that we force the pancreas to work much harder by our sugar load, meaning in terms of the amount of rice, roti, flour products that we push into our stomachs. And when that's absorbed into sugar, it forces the pancreas to produce that increasing amount of insulin. In addition to that, combining that with a sedentary lifestyle, our normal intake of sugars, we now force our body to say, let me give you a tablet to increase the insulin to keep up with your sugar load. It comes a time when the pancreas gets older, it's burning itself out, Not even the tablets will be able to work. Hence, that person now has to take exogenous insulin in addition to the tablets. Now it comes a time when the tablets will not even be working because the pancreas is not producing an insulin. Now that person is insulin dependent. So it's a type 2 diabetes, which is insulin dependent. So type 1 diabetes, there's absolutely no insulin being secreted by the pancreas. And that person is stuck with insulin for the rest of their life. And it's usually the very, very young who develop this rare condition of having antibodies that kill the beta cells of the pancreas. But what is this whole issue about diabetes and the reason why we want to have it controlled? In addition to the fact when sugar levels are high, we feel tired, fatigued, we cannot think properly, we feel things are the feet are on fire, we find that we damage our eyes, our heart, our kidneys. The whole rationale behind it is that once we control the sugar levels, those short-term complications of the tiredness, the weakness, the fatigue, the dryness, not being able to function will disappear. But what will not disappear when we start to expose, and I remember the last discussion I mentioned to you, just remember this, when we start to expose our cells at a cellular level, I'm not talking about a macrovascular level, a microvascular level, because diabetes is a microvascular disease. And you will understand this when we finish with this discussion. This blood vessel, this capillary now has a lot of sugar cells. This sugar cells is dangerous to the eyes. It is what is going to cause damage to the retina, to the blood vessels of the back of the eye. It is when uncontrolled diabetes with the high blood sugar levels in the blood vessels damage the eyes and cause diabetic retinopathy. It is the same retinopathy that causes little saccules or little vascular lesions within the eyes. It also combines that with the exudate that comes out through the walls because the blood vessels become damaged. And it can cause gradual loss of vision in the eyes by actually causing little retinal hemorrhages. And these hemorrhages themselves are very small, but actually decrease the vision. They can even produce floaters in your eyes, and you're looking at your eyes and you see these things are floating around, and you say, I wonder what's going on with my vision. But worse than that, it can cause sudden loss of vision by causing retinal detachment of the eyes itself, by blood actually going behind the retina, and you actually get a loss of vision. You can even get a state in which you actually you can see half of vision because the retina is detached on the superior portion of the eyeball itself. And that portion of the eye you can see from, but the other part you can't. We all know the role of laser treatment in terms of helping us to restore our vision. But always understand, it is so much more important for you to prevent that. Because I've always seen patients, oh yeah, there's laser treatment. If I actually become blind, yes, there's laser treatment, but so is the complication of that laser treatment. But in addition to that, your chances of having a recurrence of that same phenomena is much, much higher than the average population. In fact, it's almost about 10 times higher. So you will know, having had your first episode, you will have numerous episodes. But how much is it to understand? It's best to prevent it than to try and have it treated. The way to prevent it is to decrease the sugar loads here so you do not damage the eyes. Also, in addition to that, we have premature cataract formation in the eye because of the high glucose level. So you're damaging the retina, retinal hemorrhages, retinal exudates. You're damaging the lens of the eye by forming cataracts, by the increased sugar levels. You're also going to increase the pressure within the eyes and increase the incidence of glaucoma, much more common in a diabetic. What is your damage to the heart? So we know the damages to the eyes. What is the damage to the heart? It increased the incidence of premature heart disease. And we all know that by the increased incidence of atherosclerosis. And basically, we all know that diabetics are much more common to have heart disease. In addition to that, they're much more common to have silent cardiac events because they're not able to they do not have the classic pain that you usually get when you're having a cardiac event. We know the damage is done at a microvascular level to the kidneys in terms of damaging the blood vessels, the glomerulus, and prevents the filtration of the blood. We all know of that relative we have who's been diabetic for years and now is on dialysis. We all want to try and prevent that. The way to prevent that is controlling the sugar. So we know the damages to the eyes, to the heart, to the kidney. We also have gingivitis or gum disease. We might think it's just involvement of the gum that actually is something to worry for. No, it's not only that. It's the focus of infection from the mouth. In addition to halitosis or bad breath, it also damages the gums of the teeth, increasing the incidence of bacterial infections into the mouth. And we all can try and prevent that. It has another high level of importance with the gum disease if we have valvular heart disease, but that's another discussion. It also causes damages to the nerves, and that can be the peripheral nerve or the central nerve itself. In terms of the peripheral nerve, we all know the diabetic who is unable to actually sense heat from the stove and gets burnt on the hands, or even get a puncture wound on the leg and basically end up with having what we all describe as that chronic sore or life sore because it's unable to heal. Then they start getting debridement of that ulcer on the foot. That foot becomes reinfected again. Then we start to lose a toe. Then we lose all the digits of the toe. We are unable to walk properly because our toes are needed for balance as well. Then eventually that person becomes losing the ankle, then loses the foot. And we all have more enough information of relatives who have lost limbs based on the complications of diabetes. So in synopsis, as diabetes is a preventable condition, it is important in our population because of it's endemic in us. It's so important for us to learn as much as we can about diabetes because of it's such a preventable disease. We all know what happens at a microvascular level. We all know what happens at a macrovascular level. At a microvascular level, we go through these days when our sugars are high. That basically we feel tired and fatigued, listless. We cannot even function. To the long-term effects of it, 10, 20 years into diabetes, 10, 15 years into diabetes, we start to damage the eyes irreversibly. We've already damaged the heart. The kidneys are going. The nerve endings are going. And it's an unending series of events that results in increased morbidity and increased mortality at a younger age. We all ask ourselves, taking insulin, can we suffer with hypoglycemia? Obviously you can, but you're not going to suffer with hypoglycemic effects unless you do the wrong thing, which is basically to increase the amount of insulin. These days, they're insulin molecules which prevent the hypoglycemic attack, which we've all grown accustomed to accepting, that basically all the sugar levels get so low, the person becomes dizzy and fainting and blacks out, etc. That is no longer a problem to worry for because of the newer insulin that is available, but also the prudent management of your diabetes, measuring the blood sugar level before you stick yourself with a shorter acting insulin. But insulin education is another big topic, and just don't conclude that basically they're all types of insulin. They're all durations of insulin. They have the mechanism of action and the duration of insulin. So the discussion of insulin is not a simple topic, just knowing fully well, monitoring your blood sugar levels. And since diabetes is endemic in us, it's so easily controlled, we should consider that we can eradicate the complications. We cannot eradicate the disease of diabetes. We can eradicate the complications of diabetes if we are prudent and educated in terms of what those complications are and how it's so easy to control it. All of us listening to these presentations would definitely have had an episode or two of experiencing some kind of physical pain. We all know what emotional pain is, from the death of a loved one, from losses. But physical pain, we all have understood what it means. But we sometimes think of pain as being such a mundane and a simple experience that we think that one medication will work for all types of pain. But it's so very important for us to understand that there are different types of pains. There are different types of pain fibers that transmit different pains. There are different types of neurons that transmit pain. There are different receptors in the body, especially the extremities, the digits of the hands and the feet, that experience pain. So it's almost very important for us to understand that pain is not a unifactorial experience. It's an experience that either learned, if you've experienced it before and we know how to react to it. It's also an experience that basically different types of pains will elicit different types of response. How many times have we not looked at our grandmother and said, I never knew you could move that fast? when she puts her foot on a hot object and she moves it at such a speed. And we've also seen her react to a painful stimulus like stepping on two nails and does not react fast enough. In the absence of a condition that decreases the response, we all know that there are different pain fibers that transmits impulses, and they transmit it at different levels. If we look at our diagram, we can figure treatment is the same. The evaluation by the clinician is very, very important. Let us look at the two most common types of painful joints that we sometimes see in family practice and see how they differ from each other and how we can make the distinction. So when we know of the kind of pains that we can experience, we can say whether or not we expect any long-term sequelae. All of us who've had wear and tear of our joints, whether because of the fact of the increased amount of manual work that we've had to do in the past, increased usage, and manual work doesn't only mean I have to lift heavy stuff, using your hands tremendously in sewing and stitching, etc., using it for the nature of the work we do, carrying heavy objects, the wear and tear we place by carrying heavy objects over 20 to 30 pounds, the wear and tear you place on the lower back, the knees, the ankle itself, can result in the arthritic changes. Let's look at these two forms of joints being affected by osteoarthritis and rheumatoid arthritis. Obviously, osteoarthritis is much more common. It's the most common type of arthritis that occurs within the joints. We all can understand this is obviously the hand. This is a magnification of that hand itself. This is the hip joint, and this is the knee joint. In the case of osteoarthritis, it's the most common form of arthritis. It primarily affects the cartilage. When you look at the bone itself, each bone here is separated from the other by the cartilage, and that is the cartilage that cushions the joints. By wear and tear, we destroy the cartilage. Now that nice regular surface that was there that articulates the joint against the other in a painless existence as we've had for the majority of our lives now becomes a very painful joint. It is not hot and tender because it's not an acute inflammation. It's a old degenerative change that takes place within the joint. It's cold. It can affect the hands itself, the weight bearing, that affects the hands and the weight bearing joints itself. And it can cause pain and stiffness. The pain is a result of the cartilage damage and the erosion of the underlying bone. We actually form bone spurs in between that can be extremely painful. And to say osteoarthritis doesn't affect the hand and only rheumatoid is a fallacy. It does. It can affect it. And we can definitely see where the wear and tear takes place. So usually in osteoarthritis, it's an asymmetric presentation. It doesn't. It's not similar from one hand to the next. It involves the overusage of that particular part, and it can occur in the hands. When it occurs in the hip, obviously from heavy bending or carrying heavy weights, it destroys the articular cartilage of the head of the femur. So when it articulates with the acetabulum, it's painful. It produces, as we can see here, it's not that smooth articular surface. It produces pain. It produces stiffness. It produces the aching sensation that we sometimes experience over this area, caused by the bony erosions and the bony spurs that are formed in this area. When it occurs in the knee, it can bring a big differential diagnosis, whether or not it's due to a ligament tear. But here we can obviously see that the erosion of the articular cartilage in the distal end of the femur and also in the proximal end of the tibia, now resulting from what was usually a nice articular surface that allows the knee to move. Now we get this bony surface of which the cartilage is removed, the bony erosion and the spurs, and that's a very painful, stiff knee. You can even get swelling of that joint, especially when fluid starts to accumulate from the synovial fluid within the joint, and that joint is usually painful. So osteoarthritis is a wear and tear disease. It's a chronic kind of pain. The joint itself is not inflamed, and usually is a joint from overuse. And that is for osteoarthritis. We will talk about rheumatoid arthritis in our next presentation. In answering the question, Doctor, do I have arthritis? And if the answer to that patient is that you do not have rheumatoid arthritis, that is good news. For once you have a relative who's diagnosed with rheumatoid arthritis, it is considered a collagen vascular disease, a protein manifestation, meaning it does not only affect the joints. It can affect every organ system in the body. It can affect the linings of the brain. It can affect the linings of the lung. It can also affect the heart in addition to the joint. And it's a disease that's subject to acute exacerbations for no apparent reason. And it sometimes results in such deformity, classical rheumatoid arthritis, that you're happy for the diagnosis that I have arthritic pain due to osteoarthritis from overuse, as opposed to having rheumatoid arthritis. Getting the diagnosis of rheumatoid arthritis is usually from a blood test in which the rheumatoid factor comes back as abnormal, as a ratio 1 in 40, 1 in 80. The higher the number, the worse the prognosis, meaning that you can dilute the blood to such a degree and you will still find evidence of rheumatoid factor. I've had several patients in my practice who have rheumatoid arthritis, and basically their life is a very, very serious condition in which the morbidity of it actually prevents them from missing almost 50% of their time at work and spending almost an equivalent amount of time worrying about the disease process, because it's not only when they aggravate it, it's always there to remind you that you have rheumatoid arthritis. And most of us who've had relatives with rheumatoid arthritis will actually find out that it usually have very deforming fingers, in which they have swollen fingers, and actually the disfiguration of the joints around it can vary when they have this pannus formation, in which the inflammatory process takes place around the joint itself. Extremely painful, and when that painful condition occurs, there's very little you can do in terms of non-steroidal anti-inflammatory. Sometimes the patient definitely needs an injection even into the joint itself. As the disease becomes worse, so does the inflammation becomes it. It's usually caused by the redness, the hot sensation, warmth involving the joints that are inflamed. It usually affects the joints of the hands itself. They wake up in the morning with increasing stiffness of the hands itself, increasing warmth. Sometimes you hear them having to take gold injections on a monthly basis. It usually affects the joints of the same sides of the hand as opposed to osteoarthritis. In addition to that, osteoarthritic pains are localized to the joints being affected. In the case of rheumatoid arthritis, it's all the joints of the entire body could be affected. Most commonly, we find them presenting with the joints of the hands, the morning stiffness, the hot, tender joints itself, evidence of basically swelling within the nodes itself around the joints. But it's the pannus itself that forms in the joints in that normal closed compartment that results in the pain being exacerbated, because now the inflammation is in a closed compartment, and that compartment is now swollen, and the pain fibers within those compartments is the one that elicits the pain that these patients experience. And sometimes by decreasing the inflammation is what we're faced with. And some people think that rheumatoid arthritis cannot occur in the larger joints. Yes, it can occur in the larger joints, especially if the pannus formation is within. It can also cause erosion of the cartilage, and I've actually seen joint replacement for rheumatoid arthritis, especially when the joint surface itself is eroded and the bone itself becomes eroded. If we take a further look into the knee joint itself, when it's affected by rheumatoid arthritis, we see where the pannus is actually formed within the knee joint itself. Now, this can cause, because of the simple fact that the inflammatory process destroys the cartilage. But as opposed to osteoarthritis, where it depends on the wear and tear, this is an inflammatory process that occurs within the blood and destroys every cartilage within the joints. I've actually seen patients with the deforming arthritic pains from rheumatoid arthritis with such debilitation that they're unable to walk, they're in fact bedridden or in a wheelchair from the deformity of rheumatoid arthritis. In addition to that, when you think about the lung disease and the lung complications and the cardiac complications that occur with advanced rheumatoid arthritis, most of these patients suffer from severe depression. And most of the patients in my practice, however young they are, and even occurring as young as the ages of 20, to the point in which they basically, at the age of 40 and 50, do not have any desire to live any longer because of the severe pains and the complications associated with rheumatoid arthritis. We have addressed osteoarthritis as being the most common form of joint disease that we see in our practice, but we also see quite a few cases of rheumatoid arthritis. What I did not mention to you is that SLE, systemic lupus erythematosus, or lupus also can present with joint disease, and we'll try and address that. Fibromyalgia can also present with joint disease. We all know incidence of juvenile rheumatoid arthritis, very similar to that, but occurs much more common in a child. Gouty arthritis, by an increased amount of uric acid buildup, can also cause arthritis. The common inflammation of bursitis, tendinitis, depending whichever joint is affected, are some of the common symptoms that occur in patients. So joint pains itself is not a unifactorial description of a disease condition. It's just basically a description of the joint. Let's say it's a joint that's being affected.